please tell them to stop whatever they are doing and come here to listen to the talk. I've messaged most of them, but some of them sleep early and wake up late, so they may not have seen it. So please message every surgeon, gynecologists, urologists. I don't see a single urologist here. Where's Nainan Chaku? Please tell them all to come. We want to start and we want them to listen to Philip.
Good morning, dear BCMCH family. Again, it's a wonderful, wonderful thing to be together once a week under this banner of quest to listen to erudite scholars and to propel ourselves further. So before we start today's proceedings, may I request Philip Finney, sir, to start with a word of prayer.
Shall we stand up? Shall we pray? Our loving Heavenly Father, we just thank you for this new day, new morning, and all the new opportunities which beckon us. We pray that this morning will be a special day when we listen to Dr. Philip Varghese as he shares the advancements in the field of surgery. And I pray that you will help us to learn a few points from it and make it applicable in various ways in our institution and beyond. Thank you once again for bringing him here. I pray for his mom especially, who's recovering. I pray that you will expedite the process of healing, and may she experience your healing touch in these days. We thank you and give you all the glory. Bless every institutional member who's here and who's working in the wards as well. We ask this prayer in Jesus' most precious name. Amen. Please be seated.
Today we have an international speaker, an erudite faculty from the UK, and to introduce him and also to give a heads up on the topic, we have none other than a consultant, senior consultant, GI surgery, Dr. Sujith Philip, sir.
So nowadays when a patient comes to the OPD, there are two questions which we usually face. First question is, if it's a piles or a penile case, sir, a laser. Second thing is, if they can afford it, the robotic robot in the GM. So these are two very common questions that we nowadays face in the OPD. And to answer the best, to the second question, we are the best person here. So what is robotic surgery? Many of us wouldn't have an idea. Is robot surgery? Or is it a man who's a surgeon who's doing the surgery? Is it all hype? Can we, in an Indian setting, afford it? Then what would be indications? And nowadays when you attend conferences also, when you read papers also, all about robotic surgery. And people are, many of the corporate hospitals are also aggressively promoting it. So is it really applicable? Is it really good? To answer that, we have one of the best faculties to answer that question. And it's an honor and pleasure to have you with us, sir. Over to you, Dr. Philip Varghese.
Thank you, BCMH family, to have invited me for this talk over here. It just happened by accident when I met Dr. George Chandy, and he said, "Oh, what do you do?" I said, "My area of interest is in robotics." And he said, "Actually, we are quite keen to get robotics in over here and see how that can help the population that you all cover." So it's good to know that you have a medical director who is quite keen and pushing to get it. And he's also interested in the cost effectiveness of the program and how can you justify the cost that's involved. I know we've got quite a varied crowd here. I can see some surgeons, endocrinologists. I can see a gastroenterologist who's also a medical director with the administrative hat. I don't know about whether urologists are there and gynecologists, but there are a lot of medical students here, so it may be probably quite useful for me to know from that crowd. None of your professors are going to see you what you're interested in, but a good show of hand of who wants to do surgery among the medical students. Well, there are a couple of hands coming up, that's good. And among the people who have lifted their hands up, how many of you play Xbox or PlayStation? That's good. And the ones who didn't want to lift their hands up for surgery, how many of you do Xbox and PlayStation? Well, what I'll encourage is the ones who want to do surgery and who didn't lift their hands for Xbox and PlayStation, I would say go ahead and get a console and start practicing on it, because quite a lot of things that you do on that can be translated into actual surgical practice, because it's all about dexterity and how you can go about doing it. A brief introduction of where I work. I work in the middle of England in a place called Stoke on Trent. If you know about potteries, that's where a lot of the China pottery comes from. And my unit, we've got around 12 colorectal surgeons who purely do colorectal surgery alone, along with others. So the unit does have urologists who do robotic procedure, gynecologists, and as colorectal. Our upper GI, HPB, and thoracic teams are shortly going to start. They don't have access to the system. Bit of a disclosure, my views are quite biased, so I'll lift my hands up and say that, but once you adopt it, there's no going back. And I'm also a proctor for Intuitive Surgical, so quite a few of the slides that I have are Intuitive Surgical, but they are not the only company that does robotics. There are lots of other companies that are doing, but these are the forerunners in the robotic technology, and they are having a big impact in India itself, because they have got a big sales force over here. So it'll be good that you know that's the case. That's the hospital from an aerial view, and this is one of our 2 sites where we do all our acute work, and we have an elective cold site where we do only the day case procedures. And that's when one of the royal family members came across to inaugurate a part of our hospital building. What has been my journey through? I mean, it's not easy. It takes a long time. Similar to the questions that you have, the debates that you have here, is it cost effective? Is it worth it? Is it money well spent? I mean, as surgeons, we always say, the surgeons always like fancy tools to play along with. It's actually not a fancy tool. It's a tool that is justified. It's a tool that actually gets benefit just not for the patient, but also for the surgeon. From the surgeon point of view, it actually prolongs your longevity of actually sitting in the operating theater and operating. You're not as tired as before. So we started our program in 2014. Primarily it was for surgery and urology, but urology got a heads up and head start because of the way they could do prostates and kidneys with that. I joined the unit in end of 2015, and I started working on it from 2016. So it took me a year to actually get the program up and running. So it was so much of layers of bureaucracy that we had to go through. And the ambition we had that time was, can we migrate everything that we do laparoscopically down to robotic surgery? And can we train all the surgeons and become one of the leading units? And so far, we have achieved that goal. In my practice, I've completely moved on from laparoscopic to robotics, and I either do robotics, and if I can't do that, it will be an open surgery because lab has gone. And of the 12 surgeons, we have managed to train 9 of them, 9 colorectal surgeons. So we've got another 3 to train, but we don't have access to the system. So that is what's stopping us unless we buy another one. We started off with 1 list a week in the first year. Then the second year, we went down to 2 lists. So each list is 8 to half 7. So it's quite a long list that we have. In 2020, we decided to buy a second system. And at that time, we had what I call the old donkey, which was the SI, which was an old system, and the urologists wanted a state-of-the-art new one. So they took the new one. We were left with the old one, and we said, we will capture the old one, utilize it. And what we then did was use the system 5 days a week. And then we upgraded our second system to, again, an XI in 2021. So at the moment, we have five full-day lists of robotic surgery that we do offer. What's my ecosystem for robotics? I mean, I tend to use almost everything that's available on the platform, but at the same time, I keep an eye on the cost. That's key, that you have to justify every instrument that you're using. Most of the time, you don't need any advanced energy devices. You know, the instruments like harmonic and ligature for the non-surgeons, these are instruments that are used to take big vessels. They are quite an expensive thing even over here. And what we find is, with robotic surgery, you don't have to use any of those. All you need is a diathermy stick. And because your dissection is in such clear planes, you don't have much bleeding. And it's all respect to the plane and precision surgery. So most of the surgery you just do with diathermy. You do have a advanced device which we use to just fasten the procedure. With regards to what I've done in the last 6 years, probably around more than 280 major colorectal cancer resections, because I just do cancer work only. I'm quite passionate about teaching and education, so I'd go around teaching other surgeons who want to adopt technology, and I go then supervise and train them for the initial learning curve, which is quite a daunting task because each surgeon is a surgeon of his own profile in this institution. So you have to have that respect and the admiration for them, not to just say that you're not doing the right thing, but tell them and coach them in the right way so that they can take it forward. Prior to me even starting doing this, there's a lot of background homework that you got to do. You got to sit and do a lot of simulation. There's no going to and fro, and that's the reason I told the medical students, if you don't do Xbox, do it, because that just increases your dexterity. So I had to do at least 60 hours of simulation work on the simulator, even before I went on to my first patient. And then for your first learning curve, you have to go back and watch each of your videos. So maybe a video might be of 4 hours or 5 hours. That means you've got to sit and go through each of that 5-hour video to actually know how can you improve on what you have done. And that probably would have equated to probably 160 to 200 hours of additional work. And every time I operate, I record it, I go back, capture certain interesting pictures, and then learn from that. The good thing about Intuitive is that they've got a very good industry support. They make sure that you do the procedure the right way and for the right indication, and they come and support you for every bit of the procedure. So that's a very positive thing that they've done worldwide. Coming to what is Surgery 4.0 and what are the technological advancements that you can see in colorectal, just not colorectal, every other surgery. Similar to what you are currently seeing with all the economic and digitalization program, even things like ChatGPT, those are disruptive elements. And Surgery 4.0 is again a disruptive thing for all the surgeons, no matter what specialty you do. You are made to think outside the box. You will be made to do things that you never did before. It completely changes your look, and that disruptive force can be quite unsettling. And the reason I'm saying that is because some of you are quite experienced surgeons. You will have to unlearn things to learn something new. And if you can't do that, this is not for you. You just can't learn this new technique. You can't say that I used to do it this way, and I'm just going to use the new tool to just make my technique better. Again, that doesn't work, because it's like having a manual car and an automatic car. The principles, the car still drives, but the principles of how it works is quite different. So you have to learn to adopt to that. And once you adopt it, you will find the true, real benefit. I'm just going to a bit of a parallel thing with industrial revolution, so you can actually picture and see what actually that means to surgery itself. Of industrial revolution was when you had steam and water power to actually drive machineries, actually to drive things to automate. And that was a great thing those days. And then came the advent of electricity. Once electricity came on, you started having mass production of things. And what that then did is actually bring costs down, make it available for everybody. And then the third generation was the dawn of the computing technology, and with that brought about automation. Everybody said that's not good, but actually now looking back, that was actually very good, because you actually made the process much more quicker, sleeker. What you built was much better, and you could get much better results. And what we are living today is the world of the cyber-physical systems, where a lot of the things happen in the cloud. A lot of AI goes behind the scenes to actually decide what happens. I mean, I don't know how you are, but some of you who have been overseas, you will know that a couple of years ago, we used to have this big road maps to actually go down on the road. Nobody uses those these days. Everybody uses Google Maps or Apple. And that's all based on your system preferences. So you may have a favorite route, Sujith, to come from your home till here. And the system will recognize that's the route you normally take. And if you deviate from that, it will tell you you're going on a different route. Do you really want to go ahead? So those are behind the scenes artificial intelligence that's learning your habits and preferences. So that is the world we are in today. And what medical field, we are actually a late adopter into it, is actually trying to harness that technology and see how can we bring that to get the treatment quality of life much better. For this to happen, and this is again a parallel image of what can happen in medicine, is that every information that you have has to be interoperable. So what you capture in the surgical clinic should be interoperable with what happens in the endocrine clinic. It should be interoperable with what happens with the administrative side. Until the three marries up, you cannot, the systems can't talk to each other, and that's what happens in robotics. The information that you generate has to be very transparent. So what Sujith writes in his notes has to be known to the other person without having to spend too much of time to think about it. And what you then do is to take this information and the interoperability features and pass it on to a system, and the system will then say, well, fine, this is what I have got. Can I do the basic mundane tasks that a surgeon used to do? Can I automate and do it myself? And I'll need the surgeon only when I run into difficulty. And those are the systems we are talking about, which are going to come. It's not yet there, but it's going to come. And then what it means to the surgeon and to others is that you are decentralizing all your decision making. You don't need to be there for every bit of the case. You just need to be there for elements of the case. Now, for all of us surgeons and as human beings, what is more frightening is what happens when everything becomes autonomous. What do these mechanotropes can do? That's the most frightening thing, but probably they might do a better job. I don't know. I'm keen to look into what happens over there. Coming to scientific surgery, similar to paralleling what happened in the Industrial Revolution, we can clearly define the modern scientific surgery of dating back to 150. I'm not going beyond that because, yes, surgery even happened even before that. But I'm just concentrating on that period of 150 years that's gone past. We had three distinct phases, and we are into the fourth phase. The first phase was we were learning what anatomy is all about, what is each part of the body does. We started with the abdomen, and then we ended up in the brain. And at that phase, everything was about taking an organ out, amputation. We could not replace it. Just take it out, let the person live. And then we realized that that's not the end of it. What if we take something out and we can put something back in? So then came the phase of reconstructive surgery. Then GI surgeons, urologists, they thought, okay, let's take a part of the intestine out and let's create a conduit to join things back. So, and the pinnacle of that phase, so the second phase, was when we could take things out and transplant things in. So that you removed an organ, brought it back. And surgeons, as usual, they are always wanting to have the next level of thing. That didn't stop them. They found that, yes, we were making this massive big cuts. How can we reduce the stress of the cut and the trauma that inflict? And that was the advent of laparoscopic surgery. Probably it's become a norm now, but many of us who started laparoscopic surgery in the past, we used to consider that as a big thing, and we said, oh my God, how can I learn that technique? And once laparoscopy came into effect, what we found as laparoscopic surgeons were, yes, we were doing the procedures, but there were still a lot of things that we could not do. And I would also get Sujith's view on that because he does quite a lot of laparoscopic work, and that will be mirrored in my slides later about what the troubles he's facing and how can we address that problem. And we're into the current phase where we are trying to digitalize everything. Everything is becoming to the digital world, and that's where the robotic phase comes in. For me, the surgical revolution has got four distinct phases. The phase one was, the 1.0 was the open world, era of open surgery. Surgery 2 was the minimally invasive. We are in the current generation of and 3 was the first generation robotics we started in 2000. And we are now in generation 4, where we are trying to incorporate what we learned from 1, 2, and 3, and then trying to automate things. Can we do procedures remotely? Yes, we can do, but there are still technical hindrances that we could overcome to achieve that. For me, what Surgical 4 means is that I'm trying to use that robot as a technology. That's just one element. Mirror it with the AI information I can get, mix the two together, and have a model-based surgery. So if you have a patient coming with X problem, you have a model for that problem, and then you address that. So this is just not for colorectal. This can be exploited for anything that you want, even a field of medicine like endocrinology. Dr. Finney doesn't have to sit and look at all the values. What if I can make use of his time in doing something different? If I can automate all of his mundane tasks so that he has an output and then he just relies on that output. So that is what we are trying to do. And there's a lot of things on the Internet of Things and Internet of People. And that is the concept where in a world that is connected to each other, can we use that? The Internet of Things. That's essentially what these systems are. And the reason you're doing this is to make surgery which is more evidence-based. It is not that I did it, you did it, somebody else did it. How can I make it more evidence-based so that my patients benefit? How can I make the procedure much more safer and easier to do? And the overall aim at the end of the day is how can I improve the experience my patient's going to have, and how can I improve the outcome? But I just put that last statement over there saying that doesn't mean that robots will perform surgery on their own in future, with a caveat that I think they will end up doing at some point in future. Because we already shown that an intestinal anastomosis can be done much better in a lab bench model from a robotic system than what you and me as surgeons can do. They are much more precise as long as we tell them what to do. This does mean that you may have to think about changing the way your theater outlay is. Probably, I don't know how the theater outlay in Believers is, that probably you may have what we call as a common OR or an integrated OR. But what's lacking in the common OR and in the integrated OR is that there is no system, the systems don't talk to each other, and there's no voice integration. What then happens is the next two levels is the sensory OR and the cognitive OR. The cognitive OR, you have an open system which can communicate with each other, which talks to the X-ray team, which talks to the blood team, it talks to all your medical records, get all the information from there. And as you're going to operate on your patients, all this information is pulled in. So you as a surgeon can then look at everything and make a decision. And eventually that translates to the outcome, which then feeds back to the information system that your IT team will be gathering. So that is an eventual aim, that we all move from a common OR situation to a sensor OR or to a cognitive OR. Cognitive OR will take time to come. So that was a brief intro of what we are, where we are and what we are facing. Coming specifically to robotics in colorectal surgery, I mean, urology was one of the leaders in robotic surgery, and the reason was that when they were doing prostate surgeries, trying to get down so low down to do the surgery and to get a good result was difficult. And for them, again, nerve preservation was important. And they were just operating in just one field. They didn't have to do what we call as multi-quadrant surgery. So that's why it was easier to adopt this in urology, and then gradually it moved to other specialties. GI surgery is always multi-quadrant. What I mean by multi-quadrant is that you're just not focused in one area of pelvis, but you've got to keep moving to different areas. And to do that, the system has to be forgiving and it has to do what you want. And it's a bit more daunting task. And that is the reason colorectal took a bit more to come on board, but now that it's come on board, it's reaping the benefits of it. The market is quite crowded. It's just not Intuitive Surgical that's there, but they are the big beast in the field. But there are a lot of other people that have come on. And this slide I've taken from, there's a company called Verb Surgical, which was a collaboration between Google, Verily, and Ethicon. They had very good ideas to do it, but you can see they have dropped down right to the bottom of that. What happened is they had the idea, but they could not get a product out of it because it's so complex. So at some point they might rise back again and have come up with a system that might be useful. But we do have systems which are useful for orthopedic surgeons. We have systems that are useful for GI surgery. So the numbers keep increasing. But I don't have experience with every system, but what I've seen is Intuitive Surgery, which I do use, but I've also seen a couple of other new systems that's come on board, and I'll show a couple of slides of that. So this is my OR theater, and this is the new XI. We had the old donkey, which was the SI, which has been given away. And the chap right on the right of me with the beard is one of my surgical first assists. He's the corner of what I do. These days I don't have to scrub at all. He's a nurse by background who has been trained and upskilled. So he puts the ports for me, he positions the patient, he positions the ball, and all I do is just go and operate. And then he closes the abdomen up. So I can say that I've forgotten scrubbing also. I don't have to scrub. But that is a stage that you will reach to. But it's a team effort. It's just not that you're doing it. You need a team. And I'll go through how you want to, because the institution here is keen, I'll go through how you want to set up a team to get the product out. So what you see on the left is the XI system. And what you see on the right is the new system, which is called the SI, if the video plays. So you can see what they've done is they have miniaturized everything that was on the left, which is still the active new system, into a single 2.5 millimeter port, 2.5 centimeter port. So you still have 4 instruments coming through the 2.5 centimeter port doing the same surgery. The SP system, which is currently available, is only licensed for urology and head and neck surgeries. It's licensed to be used in GI surgery only in Korea and America. It's still not come to the rest of the world because we still have some teething issues with staplers and all. So what you're going to find, what you're going to use for the next 10 years is the system on the left, which is the XI system, which is quite a very good multi-quadrant system. This is the newer kid on the block from Medtronic. It's called as Hugo. It's very good, but it's got its own limitations, and I'm sure Medtronic will address that in future, where they're going to get staplers and energy devices added onto it. And it's got 4 independent arms, and you can use as many as arms you want, depending on the procedure you're doing. The main difference is that, this is me working on a sim when they got the system, is that, so let me just see where the video plays, is that it's an open console system. Well, the video doesn't want to play. It's much more of an open system, so you don't have that immersive experience. You can see things that are happening in the background. Probably they might change it to a curved screen in future. And we also got a Cambridge Medicals called CMR, which I think is available again in India, which again has a similar sort of a modular platform. Again, it does the work, but does it do the same amount of work that I would like for colorectal is debatable. When I thought I'd seen it all, and I went for a recent conference in America, now they've got even systems which are going through 5 millimeter port, which can be used for laparoscopic surgery. And that is the pace at which the systems are moving. Looks like, sorry, the video doesn't want to work, so I'll skip that. So these are 5 millimeter ports, which can be used through a standard laparoscopic port. Again, it does the work. So what I'm talking today might not be relevant even tomorrow. It might change. So that is the thing I have to be mindful of, that I should be willing to change along with what's happening over here. As I said, since 2000, the field of colorectal has increased. Adoptions of robotics have really gone up. And when we looked at it in 2017, we have close to 4,500 systems in place. But the last 6 years, the systems have actually doubled. And that is the pace at which people are adopting. Adoption is not just that you need to have the kit. The adoption is because you are having better results from what you're performing. What are the advantages of the current system and why I have taken it on? I find that I can do the docking much quicker. The instruments are much slimmer, so I do things through an 8 millimeter port. I can offer multi-quadrant surgery, and I have all the advanced instrumentation along with technology to assess perfusion, which is quite key when we do GI surgery and anastomosis. The system is much more stable. In laparoscopy, we trained ourselves to look through a 2D platform, and we learned our brains to learn that's what it is. But actually, when you sit down in this room and what you see today is a 3D picture, and if you imagine you can have the same depth perception when you're doing the operation, that makes your life much better because you can be more precise. Laparoscopy, the instruments used to work as a chopstick. You can never bend it. But over here, it's just like your normal hand. You can bend, turn, have a wristed thing. And when you go into deeper spaces, it's much more easier. As you know, we surgeons are not perfect. We all have tremors. Actually, the system takes away all your tremors. So you're actually much more controlled. And you can do a better procedure by doing this. So if you have somebody who's got tremor, I would say get onto robotics. It's much better because the system filters your tremor out and helps you to do it better. And what it also does is it makes you do procedures. It makes you push the thresholds and the boundaries of what you want to do because it becomes much more easier. I look at it and say, places where I would have done a stoma because I could not join. I now go and join it because I can do it. I was talking to Sujith this morning. He's got a case, interesting case tomorrow where he has to do quite a wide, extensive surgery. Probably if he had the system available, that would have made his life easier. Probably you may say that back in a year's time, saying that I should have had that then. But that is what it is, because it can push everything forward. What robotics brings to me is the concept of precision surgery. Everything that you do is precise. You respect your embryological pain. You do very little tissue trauma. So what that then translates is the less tissue trauma, earlier recovery. And if you're dealing with tumors, you're going to have very little tumor handling. And I say, if it looks good, it works well too. A lot of us, when we were getting trained in the 90s, we never had laparoscopic surgery even. We had established open surgeons who were the gods of the era. And at that time, we had the new kids in the block who learned laparoscopic surgery and came on. And there was a great divide between open surgery and laparoscopic surgery. And the open surgeons used to say, that's a rubbish technique. It won't go anywhere. The way you have to do is open surgery. And the poor laparoscopic surgeons used to say, actually, laparoscopic surgery is better. But there's a big conflict. And for organizations trying to adopt laparoscopy then was quite expensive. So they went with the open surgeons who were in pretty high, big positions in the organizations, saying that, what do you want? And they'll say, I think open is better. We don't have to go for that. So coming to that, what I say is the open surgery is well established. There was no learning curve because they were doing it for so many years. There was a lot of evidence that was published with regards to oncology, with regards to outcomes. It was cost effective and it was quick operating time. And patients accepted it. Patients wanted a big cut. They used to feel a big cut means they can see better. The lap surgery at that time was quite a new technique. It used to take a long operating time. And sometimes you may be surprised that to do a gallbladder those days used to take 12 hours, unlike what it takes 45 minutes these days. But that was a learning curve even for a simple procedure like doing a lap chole. The learning curve was very high and it was very expensive. And because you had a lot of long operating theaters, you could not do the same number of cases. And your boss was not happy or your organization was not happy because you're not bringing the money in for running of the institution. And there was a big skill gap. So that was a problem there. But what happened with the test of time is that that's become the gold standard. Laparoscopic surgery became the gold standard because we could show by evidence that that works better. And in UK, our NICE guidelines for colorectal cancer states that you should offer lap surgery as the first protocol. And what made the real difference is that technology improved. We were able to upskill and train everybody. Like in UK, we had to train consultants. We had the national training program for consultants to be trained. We had fellowships. And there was information that went to the patients. The patients became empowered. They came asking for laparoscopic surgery. They knew it was better. And we could show it was more cost effective. Now, before I go to the next slide, I just want to have a quick word from Sujith about what are the challenges that he faces when he does rectal surgery, especially in the pelvis. And let's see whether his experience actually mirrors the slide I'm going to actually put, because I'm sure it's going to be the same thing that I've written in my next slide. And that's a force for Dr. George Chandy to actually say, actually, I think I should get it over here. Okay, Sujith, off to you. What do you think makes your life difficult in the pelvis when you're doing a rectal surgery?
Yeah, pelvic surgery for clear rectum. Real indication that's difficult when doing laparoscopy, even open also. The first issue is the depth. You're not able to get the visualize. The first issue is the depth. We are not able to get the visualization when going into the depth. Other thing is the how we can manipulate our instrument. If there's any bleeding or anything, it's difficult to control when we are doing it laparoscopy because we are not able to. These are rigid, long instruments, so we are not able to manipulate it and control the bleedings. So visualization, the manipulation, and the access, especially in tall or obese people, especially males, it's difficult to access to get access to the lower pelvis. So these are a few difficulties that we face with the operator in the pelvis.
And I'm sure the urologist again will have a similar view. And let's see, I think we both were mind reading each other. When I made the slide, I could see what Sujith is going to say. So this is exactly what he said. I have got problems in exposure in the pelvis. I've got problems with retracting the tissue. Especially the access is very difficult in lower down in the pelvis. If somebody had radiotherapy, it becomes even difficult. Everything is scarred up. Male patients, how do I get the stapler down there? And the peer pressure of people actually watching you do it. What's this guy doing? He's still struggling there. But it's actually not Sujith's fault. It's the fault of the anatomy. It's the narrow box. So the history repeats itself again. Exactly what we did in 1990 with lap and open surgery, the history repeats now with laparoscopic surgery and robotic surgery. Now robotic surgery is a new kid in the block, and we are telling exactly the same story which I showed you in 2 slides before. No evidence, it's expensive, can't be done, it's absolutely useless. Why do you want to waste your time? And Sujith is an experienced laparoscopic surgeon. He will say, well, I don't want that. I can do 3 cases now laparoscopically. If I adopt that, I'm just going to do 1 case. It's not good. Or Sujith might say, I don't want to learn that new technique because everybody is watching me. But what really matters to me is a couple of 5 key pillars. One is better short-term outcomes. Your patients come in, they get operated, day 2, day 3, they are out of the hospital. You are able to actually improve the outcomes of the patient. The leak rates go down, the blood loss go down. In robotic surgery, when we do, the maximum amount of blood loss we have is probably around 10 ml of blood doing a major resection. Probably 1 little swab will just get soaked with a few specks of blood. That's the degree we are talking about. You do not have anastomotic leaks because you have other advanced techniques which can pick up those problems. And when then you look at the long-term outcomes, people having robotic surgery, the oncological outcomes are much better. And the reason they are much better is because you start doing things that you never did before. You go harvest lymph nodes that are involved, you take them out. Cancers that you thought can't be cured can then be cured by this procedure because you are then becoming more and more aggressive. You improve the quality of life for your patients. Stoma is not a good thing for patients to live with. They have problems with stoma, they have problems with things. So if you can improve the quality of life, that's much better. Sexual dysfunction is not a good thing for colorectal patients. It's a thing that's never talked about, but that affects the quality of life. If you can preserve the nerves and give them a better quality of life, that's much better. And what robotic has done to me is that it has standardized my procedure. If I do, it's exactly the same thing somebody else will do. We all sing and dance to the same hymn sheet. And as a result, the outcomes get better. And for me as a surgeon, the surgeon is always a forgotten element in any OR. We always have quite a lot of repetitive trauma to our wrist, to our neck, and that shortens the life of the surgeon. We never realize that that happens. And this actually takes that away. You are sitting down comfortably, operating. You can do the same number or even more because the technology offers that to you. And it's all become possible due to the good vision that you get, the precision that you have, the freedom to go to deep spaces, having a stable platform, and all of the other things that I talked to about before. Probably in believers, what you have today is the minimally invasive surgery component, which is the lower part of the graph, where you are able to do anastomosis. Yes, you can do, but it struggles. You can close, you can use advanced energy devices, and all the traditional benefits are there. What you then do by getting a robotic system or a next platform is the vision, the precision. And once you've adopted that technology, when you move down to the 3rd level, which will happen in the next 10 years, is the level of automation. So if you don't adopt the 2nd level, trying to jump to the 3rd level is going to be difficult. And I would then say, yes, you're doing a work, but the work you do becomes irrelevant. And I take the example of Mavelikara, the place where I live. It used to be a bustling city many years ago, before Tiruvalla came up, before MC Road came up, and before NH came up. And I call that as a Route 66 from Tiruvalla to Mavelikara to Kayankulam. Because these 2 high-powered roads came up, developments came up in Tiruvalla and in Kayankulam and other areas, and Mavelikara got forgotten. And what you need to do is to make sure that you don't get forgotten for the good work that you do. And for that, it means that you have to stay with the time of what's happening. We still have a lot of arguments about robotic system. people are not willing to change. And that is, I always say that, because if you're not willing to change what you're doing, don't think about it. You're not going to get any benefit of it. We still have problems that it's not available to the general masses. So it's very focused, and in Kerala itself, you have probably 2 or 3 organizations that offer it. So it's all focused to few places. It's a big skill gap. And what I mean is that although system is there, not many can do it well because they've not gone through the proper training program. And again, you've got to justify the cost and the benefit. For me, when we looked at our data, is it cost effective? Yes, the system cost is offset by the shorter stay, better outcome, lesser requirement for analgesia. And as we increase the case numbers, the overall costs come down. And we looked at our actual costings for rectal cancers and for colonic cancer. I don't have that slide here. But what we found was that if you were to do a cost avoidance, and what cost avoidance means is that if you're doing 100 laparoscopic cases and you want to convert all the 100 lab rectums to a robotic procedure, from a UK situation, we were saving something like £750,000 by the 100% conversion. Even if you don't convert 100%, let's say you convert 50%, you still save £350,000. And if you put that £350,000 in 3 years, you actually made the cost of the system. That's just one specialty. But if you're using it for many other specialties, then it becomes cost neutral. And that is what we are finding. You cannot look at the cost right at the start of your program because you're going to be slow in your learning curve. But as your learning curve improves, it becomes cost benefit. This is a paper from America where they looked at colorectal programs, and again they found that in 2017 there was close to 160% increase in RAS procedures. But America is different. The model is different, so probably that is reflective of that. But that's something similar that what we are finding over here too. To become successful, you have to do these procedures day in and day out. You can't be a surgeon who does one procedure a month and then forget about it. You have to call, the volume does translate into what you do. So if you have a unit that is having a good input of patients coming in, probably this will be good. So I can see, at least for this hospital, urology, gynecology, and GI surgery being the starters in doing it, followed by ENT, who can actually use the system for all their ENT-related works again. And thoracics, if you have, that's another field where you can, instead of doing a VATS, they can do a robotic pneumotomy, and there's much better outcomes come from that. Do you need prior laparoscopic experience? And that's the struggle Sujith and other gynecologists and urologists will have. I'm a laparoscopy surgeon, can I do it better? Now, there are studies which have shown that if you're a laparoscopy surgeon, your learning curve is quicker. Probably I will disagree with that. I would say you just have to have the passion to learn it. Because once you sit on the console, it's like doing open surgery. It is no longer like laparoscopic surgery. You're using your wrist and hand. Everything is surgery under high magnification with precision. For colorectal surgery, the key is trying to get the urogenital function preserved. You have the splanchnic nerves, you have the hypogastric nerves, which are important for urinary and sexual dysfunction. And what robotic surgery enables is to preserve these nerves. This was the forte of the urologists. They used to say, we got these nerves that we had to preserve for our patients. But actually, it's more important for colorectal patients because our patients have radiotherapy. These nerves get blasted off in radiotherapy. So we are able to preserve it. And I, as a routine, talk to them about sexual and urinary function. And they come back and tell me. If I'd never talked about it, they would never come back and tell me. But it's important that we think about it. So for colorectal surgeons doing cancer resection, it's just not treating the cancer and achieving a complete clearance that is good. What is also important is the hidden fact of all these soft things that patients may not tell you, but that actually affects your quality of life. There is growing evidence now that robotic surgery actually has a better overall outcome when you look at your survival and also for cancer-free overall survival and cancer-free survival, it's got a better outcome. And although it's not statistically significant there, but that's being, because that paper is a bit old, it is shown now that it gets much better. I was also talking about all these advanced technologies that we have where you can assess perfusion. For any joint to heal, you need good blood flow, you need to be tension-free, and we've got a new thing that the gut microbiome has to be the right thing. So those are multiple factors, but let's address at vascularity. Earlier we used to just look at a bowel and say, oh, it's looking pink and warm, or we used to divide it, let it bleed and say it's a good bleeding, so it survives. But what robotic systems help you is to do near infrared fluorescent imaging to actually look at blood flow, and that makes a big decision in how you can get it to work. So let's see whether this video works. So there's a anything that is looking green there is what is viable. So I know that when I'm dividing the bowel, the stuff that's looking green will survive, the stuff that is looking black will die. So when I do the joint, I'm more confident. And how does this translate to rectal surgery? If I know that the joint is good, I don't have to give a stoma. I can just rely on the technology to tell me what is happening. This was a big taboo before. Never join a bowel, inside the belly. There's all feces coming out, there'll be infection. But that's just a myth. You can still do all anastomosis inside the belly. As a result, you don't have to mobilize so much of bowel. You just do what is required and then join things in. And when I'm doing the joint, again, I can see the perfusion that is there. I know that bowel is healthy. I can see every stitch that goes in is more precise. I'll just let it run for a couple of seconds. You can see traditionally used to doing laparoscopic surgery, you just had 2 hands. Over here, I have got 4 hands. I've got 3 hands of the system and the 4th hand of my assistant. So obviously 4 is better than 2. Now the tip of that needle holder is 5 millimeter. So you can see that it's quite a magnified picture. So let's go to the next one. To have the technology much better, you've got to have a structured training. And the structured training is similar to what I had, which was going through the program and then going through my continued learning process. Whether you do it here is exactly going to be the same thing. And the training concept is going to start you with being a beginner to the advanced and getting you more competent and then making you completely proficient. And that takes time, so we've got to be willing to accept that. Probably this is not that relevant for this crowd over here, probably more for Sujith and his team, how we do the training. But probably I'll dwell on this bit about how do you go about getting your program up and running. His first thing is just not the surgeon. You've got to identify the key nurses and the OR staff, the key anesthetists, because they are part of your team, and then you've got to standardize the procedure. So if you're going to start the program, you have to take all of these groups to get trained, and that is something that you've got to think about. And you've got to believe that the system is just not for one person, it's for everybody to use. So you don't just grab hold of it and keep it for yourself, and then make sure that everybody can use that. This is the common problem that we normally face, is where you have the new technology, everybody is keen to do it, you start doing it, you start having problems, you reach the level of peak inflation and you reach the maximum expectation, you have complications, and you just drop down and you have a trough of disillusionment. What I don't want teams to have is that you go through this curve. Even if you don't have a steep rise, as long as you can keep the program up and running in a steady fashion, that's the key. To conclude, what I would say is that it's all about precision surgery. To me, this provides the best tool. I can standardize, I can train people, I can tell them what it is. As Sujith was introducing, there's an increasing acceptance from patients and the profession. So people are going to come and ask you, can I have it? And with time, evidence will come, and we will be able to develop model-based surgery through robotics. What I want is the group over here to actually start thinking, why shouldn't we do it? And how can we do it in a better way? So that's my team down there, where we started the program. And as I went along the journey, I said I need to learn new things. So learning new things is just not sitting in my own little cocoon. So I went down to Japan to learn a procedure, and that's a team. Now, the chap here is a professor in Tokyo. You can see a collar that he's got, and that he calls as the Da Vinci collar. So when he started the procedure, nobody told him that if you bend the neck too much, you can have cervical spondylosis, and that's what he had. So we have learned this now, and we have made it better. Thanks a lot. And while we are closing, I'll just let this video run, and then I'm happy to take some questions from you all.
Thank you, sir. Thank you for a wonderful talk. Thank you for making us think. Thank you for expanding our horizons and making us think the way surgery is going forward now. Time for questions. Any doubts, any comments? Can I ask one question to start off? I agree that robotic surgery is very relevant for complex surgeries, for difficult surgeries. But how useful it could be for a routine surgery, let's say cholecystectomy or a lapping on hernia, because anyway the patient is going to go home the next day. So will robotic surgery make a difference for such surgery which are not very difficult?
So the question I'll ask Sujith is, what all do you use for a lap hernia? Just quick things that you use for a lap hernia. You use a barred 3D mesh, you use a tacker, and you use disposable ports. Yeah, each disposable port is around, for us in UK, it's around 100 pounds or 70 pounds. A tacker costs us around 250 pounds. The barred mesh is around 200 pounds. Yeah, a robotic instrument which is reusable for 10 cases, each instrument costs 100 pounds. So for me, the two instruments are 200 pounds. The mesh is the cheapest mesh I can get, and I just use a suture to suture it. And the procedure is done within 15-20 minutes. Patient still goes, but I'm making money, saving money for the organization.
Yes, thank you very much for your presentation. It was very enlightening and an eye-opener. Just two simple doubts. Number one, what would be the average training time you think will be required for a person who has no laparoscopic experience? Second, for a person who is a well-trained laparoscopic surgeon.
Okay, that's a very interesting question. I'll address that question in two ways. That I don't know whether you do lap surgery or open surgery. If you look at one of my slides, which I said, once you sit on the console, it's like doing open surgery. It's exactly like what you did for open surgery. So for me to train an open surgeon is much easier and quicker than training a lap surgeon. That doesn't mean that I can't train a lap surgeon. A lap surgeon can be trained provided he forgets all of the laparoscopic things that he learned, of holding things, pushing it down. You have to unlearn that. If you're not going to unlearn that and you do that in the system will do exactly what you want. You do not have a haptic feedback, so you can cause more harm than good. So both the groups can be trained easily. The learning curve entirely depends on how much of time you spend on simulation. And that's the reason I was telling the crowd that my first assist, who's a nurse, he's a very good PlayStation player. His course on the console, on the system, on the simulator is much far ahead of what me or my colleague could attain, because he was so very quick. So it's how much of time you spend on simulation, how are you willing to change what you do, and the third thing is, are you willing to go back and spend that 4 hours looking through your videos? Because you then pick up things that you want to change.
Sorry, we are running a little short of time. Dr. Vinod, were you about to ask? Dr. Thomas? Yes. And then we'll have Dr. George Chandy to say a comment.
I was impressed by your interest. Seeing your title slide, it mentions surgical education. And so I was wondering, seeing you adopting new things, whether it's the environment in the UK that makes you feel free and interested in self-improvement and education,
I mean, education has always been one of my key things about how we make learning better. For me, it's about every individual should be free to express what they have, no matter how silly the idea may be. That silly idea may be silly for that person, but it might be one of the innovative ideas. So I always tell every person in my OR, right from medical students to my junior interns, that if you think there is something different that you can do, speak out. And that is the culture that we have to actually start right from medical school, from the students saying that I think I can do something different. What do you think about this idea? And those little ideas become a big thing. And the reason I'm saying this is that way back when I was doing my MS in Velo, I thought about doing sentinel lymph nodes for breast cancers. And I did, and this was just an innovative thing. I thought, if you're using it for penile cancers, why can't we use for breast cancers? I did propose it, but the culture was different then. They said, oh, no, this is complete rubbish. Halstead said, do this, so we do this. Fast forward 10 years down the line, 1999, when I went down to UK, that comes as one of the projects. And I said, actually, this was my idea a couple of years ago. So what I would say is that everybody should have the freedom to express, no matter what it is. It may be completely ground shaking. It may be completely against what you normally believe in. And you as a lead should be willing to accept it. Actually, that's good. I'm going to change that. And once you have that culture, I think progress comes.
Thank you, Dr. Thomas Chaku, for that question. And I just want to promise you that this is available here. It's up to you to use your time. Okay? Anytime. Three things very quickly. Philip, thank you so much for setting aside time for us. And Philip Finney, batchmate, 1991 batch CMC, for having brought him to us. Thomas Matthew, Biju and team for looking after his mother to make sure that he stays on with us for 3 weeks. 1 week is over. There are only 2 more weeks where we have Philip Varghese. I mean, this is just God sent to have him here with us. So I want Rennie, I want Sujith, all of you, please make best use of him. He's a born teacher. He loves to teach. Deepa, all of you, urologists, please, because he taught me in a very short while that this is viable. And unlike many other surgeons, he taught me the economics of it. So I'm convinced, but then all of you must make sure that we go through the processes that he said. 1992 is when I went to Australia to train in liver transplantation. What happened was I went there during Easter time, April. That summer, all the surgeons, senior surgeons disappeared. And I'm looking around for friends whom I had made. They were not there. They'd all gone to UK to train from Australia, to train in laparoscopic surgery. Because the people who said that laparoscopy doesn't work came back after a couple of months training and said laparoscopy is the way to go. So there's a deja vu here. I get a feeling that soon we'll be saying robotics is the only way to go, and we have to be there. So please force the management to do what it should, so that, and we have a lodestar, somebody here who's an icon in this area, ready to teach, ready to guide us. Philip, thank you very, very much.
You.
So thank you very much for staying back and attending the session. I'm sure we've got enough food for thought. I request the surgeons to please try and meet Philip while he's here. His mum is in 3rd private ward, and if any of you want to fix an appointment, we'll be happy to facilitate a time so that he can share with you. Even you could have small group discussions, I think, among the surgical teams, urology, gynecology. That'll be good. Thank you very much, and see you next week, same time, same place.